Hi, my name is Jürgen Rockstroh from the Department of Medicine, University Hospital in Bonn. And I'm going to talk today on the COVID-19 epidemic in Germany. What have we learned? And does underlying HIV infection make a difference? Really trying to share some of our first-line experience with you. This is my conflict of interest. So let me start with epidemiology, and then I'm going to cover some aspects around testing, the clinical course of disease, patients with HIV co-infection, and some general learnings. Starting with the epidemiology, it all started in January 2020 when a Chinese businesswoman came to train some German co-workers, and then the first individual became sick with sore throat, chills, and myalgias on January 24th, and subsequent a COVID-19 infection was diagnosed also with some co-workers. So that was the first cascade of infection coming really through transmission from a Chinese co-worker who came asymptomatic to Germany, had no symptoms, but transmitted the virus to several attendees of this particular training session. Now, if you look at the Johns Hopkins Coronavirus Resource Center world map of today, 30th of April, 2020, you can see that what started with a lot of cases in China and then eventually very few cases in January in Germany has really exploded and has now reached over 3 million infections worldwide. And you can see that Germany currently has 161,000 infections and is a little less than what you see in the United Kingdom, France, Italy, and clearly in Spain, where the most European infections have been diagnosed. Now, if you look at the distribution of laboratory confirmed cases of COVID-19 in the EU and the associated area and UK, you can again see that it's mainly these big countries, Spain, Italy, France, Germany, and UK, which are affected. And you can see the initial increases in cases, which is now leveling off pretty much in all the different affected countries. Now, looking at the death rate, you can easily see that in Germany, we only have 6,115 deaths of the 29th of April. And if you compare that to the death rate in Spain, Italy, and UK, although they have more infections, but you can see that by far, many more patients have died. So that obviously has prompted the question, why is the epidemic different in Germany? Why do we see less deaths in the patients? This slide summarizes the German-specific numbers. It's always a little variation. This is from the official public health office in Germany, so it's always a little bit different than the Johns Hopkins Resource Center. So you see this is a little bit lower, but again, you see around 160,000 confirmed cases, 6,000 deaths, 120,000 resolved infections, and 87% of deaths, but only 19% of all cases occurred in persons age 70 years or older. So age is a key figure in assessing the death rate. You can also see on the right-hand side the numbers in the various regions and provinces of Germany, and you can see that in particular Baden-Württemberg and Bavaria, as well as North Rhine-Westphalia, those are the three most affected provinces. So obviously there are also regional differences, and that also had some impact on how the regions respond with regard to closing borders or social distancing or requirement to wear a mask and so forth, because the numbers are not the same throughout all different regions. Now, if you look at the big differences in the mortality rates, particularly between Spain, Italy, and Germany, I think there's several things to say. The first is that we simply had different testing strategies. So I think one of our big advantages was that the colleagues from Christian Drosten and his team at the Charité in Berlin developed the first sort of test. So very early on in the epidemic, and obviously having the advantage of having the test developed, that he's passed on the test details to the WHO, we were able to have testing. Now, testing is also not centralized, so it's not only in Berlin where testing occurs, but it occurs in all different kind of university virology laboratories, but also commercial laboratories. So there's a much more expanded testing because you can send it to many different labs who have all set up the corresponding technology. So we did a lot of testing, and I remember I was on call the first week when the epidemic unfolded, and we also tested the first patient in our region at our hospital during my call. And the interesting thing here was that of the first 300 patients we tested, there was only one positive. So it tells you also that we tested a lot of people who either just had a suspicion or had contact with someone who had, but really had a very low risk. And then of those who we tested, a lot were asymptomatic and were isolated early, so they could not transmit the virus to others. So I think the more rigid testing, including asymptomatic individuals or those who had a risk exposure, and the consequent site of isolation prevented further spread, rather than countries where patients were mostly tested when they came to the hospital but were already severely sick. So you have a bias because you have a much other patient population. You're missing the asymptomatic ones, but having the more severe sick ones. And then obviously the mortality rates of those patients is going to be higher. The second big difference is, and this was particularly apparent between the Italian and the German situation, there was a huge difference in median age. So the patients in Italy were around 15 years older on average than the German patients. So the first two big cluster infections, other than the one in connection with the Chinese businesswoman, was a carnival's party in Heinsberg, where a lot of infections occurred, and then a lot of people who got infected in Ischgl in Austria during their skiing trip. And so these are usually healthy young people. And so initially, the virus spread, particularly in this very young patient population, explaining the huge age difference. We also have on average 10 years younger population than, for example, also in the United States and New York. So this may explain also the lower mortality rate, because obviously the highest death toll is found in the old patients. In Italy, there are more three-generation households, so meaning that if you have your grandparents living in your house, then obviously if young people got infected, they were more likely to also infect their grandparents. And this three-generation household is not so common found in Germany in comparison to Italy. Also, I think the infrastructure in Germany is pretty well equipped. So we do have on average a much higher number of intensive care beds than our surrounding neighbors. So obviously we're better prepared for a bigger requirement for intensive care beds, which is probably also helpful, because I think one of the general messages which has come out of the ventilation of COVID patients is that usually they remain on a mechanical ventilation for very long, on average 3 to 4 weeks. So obviously if you have your beds full, these patients are there to stay, and obviously then get very fast, it becomes difficult to find new respirators for patients, because they still have the same other patients on the ventilation for those 3-4 weeks, and then obviously that blocks the beds as well. And then there were obviously differences in political responses, thinking of the UK, where there was no sense of isolation measures in the beginning, whereas in Germany, I think there was a pretty proactive social distancing initiated and closure of schools, universities, kindergartens, and similar institutions and public health offices to prevent further spread of disease. And I think the social distancing also has been followed pretty vigorously in our country. Now, looking at the testing, obviously the PCR tests can be done on respiratory samples obtained from nasopharyngeal swab or sputum samples, and it's become the gold standard. I think one of the bottlenecks initially was that it took quite a while to get the results. So it does take a while, but particularly with an increasing demand of testing, it took a while. And then there's obviously the serology, which is the production of IgM and IgG, which follows upon infection. But it does take a while. And we'll come to that in just a minute. Then there are also assays which can be performed in central laboratories or by point of care. And then obviously there's a need, particularly in people who have an increased risk, medical staff, for example, to get tested regularly. And in order to save material, because there's also a shortage in chemicals used for these procedures, some hospitals have started doing block tests using the swabs of 10 employees. And I'll show you one paper around that. Now, I think one of the signature papers from Germany comes from Christian Drosten's group from Berlin, who really looked at the very first cluster of patients in Schwabing in Munich in the hospital, where he took stool, blood, urine, and swab and sputum samples on a daily basis in 9 individuals, and was really able to show that pharyngeal virus shedding was very high during the first weeks, where patients usually had no symptoms or very little symptoms. And I think that sort of underlines maybe also why the transmissibility is so high, because people have no symptoms, but because of the high concentration of viral replication or a replicating virus in the upper respiratory tract, it's really easy to transmit. It's of note that in the stool samples, no culture was ever positive. So although you can isolate virus continuously, does not seem to be infectious. Blood and urine never yielded virus. And then I think what is also important is that there are changes over time. So whereas you start with a big replication in the upper respiratory tract, then moves down to the lower respiratory tract, and you can be negative in the upper respiratory tract sample, but then positive in the lower. So you also have to look at different sites during different phases of the infection. Shedding of viral RNA from sputum outlasted the end of symptoms. Seroconversion occurred after 7 days in 50% of patients, and then in everyone after 2 weeks. So serology is not very helpful in the beginning of the epidemic or of the acute diagnosis phase, because it takes a while to develop the antibodies. And there was no association in the serology between the decline in viral load or viral load altogether. And so I think for acute diagnosis, serology is really not helpful. It's really more probably a tool for surveillance. This is taking the figures from the Nature publication from Dawson's group, showing you all the different time points when samples from the various specimens was taken. And then you see the RNA concentrations by throat swabs and oropharyngeal swabs over time, how that declines. And you can also see indeed the course of serology, 50% positive after day 7, and then all at the end after 2 weeks. And then also looking at the cultures and how that depends on viral load. So the higher the viral load, the more likely is the positivity of the virus culture. And what was important is that some of the sputums tended to remain positive, whereas swabs were ID negative. And I think that's also important diagnostics. I'll give you an example from our ward, where one patient came with suspected pneumonia. We thought he had COVID-19. His swab from the upper respiratory tract was negative, but then it did turn out that he was positive from the sputum. So it was already in the lower part of the respiratory tract. And unfortunately, isolation was stopped after the negative PCR from the upper respiratory tract came back and subsequently infected 3 nurses from the ward. So it's really important to keep people isolated to be really sure that at none of the sites you have ongoing infectious replication. Remaining challenges is that when viral load, the pharyngeal PCR can become negative, the sputum can still be positive. That's what I just outlined before. ELISA tests may have low specificity and sensitivity, so more test evaluations need to happen. There clearly is a real quest for increasing testing capacities, and it's also about ordering enough chemicals to be able to prepare the PCR preparations. And then I think it's time to test different strategies, and obviously there are also different regional demands. So we have on the countryside, there's not a testing site everywhere, but they've now developed like a car which sort of serves the entire region and goes by and does swab for people where there is a suspicion of COVID-19. So you have to also be imaginative and think of some mobile testing units, for example. There's also been the establishment of a drive-through testing, for example, in the Netherlands. And I think these are good examples of how you can develop new efficient testing strategies in your respective country. Now, with the difficulties around PCR and the time, there was also an interest in looking at rapid point of care testing, and our virologist Hendrik Streeck was one of the first things he did was try to look at recently developed rapid tests. Unfortunately, some of the individuals who were positive by PCR did not test positive with the rapid test. So the sensitivity was low with only 36%. The specificity was 88%. And so obviously with the low sensitivity, antibody-based rapid testing for public health measures was not to be recommended. Our virologist also established a test where he sort of pooled 10 swabs together and did mini pools for testing in order to save material and reduce costs, and that worked very well. This is a cooperation, and this has been published, as you can see down here. So that is also maybe something to think of. Looking at the clinical course, I think I just want to highlight that there seems to be different disease stages. The first one is the already alluded to replicative stage, where you have high replication, usually in the the nose or in the upper respiratory tract, with an innate immune response, usually not too many symptoms or only mild symptoms, and then an adaptive immune system kicks in and increases levels of inflammatory cytokines, can lead to tissue damage and clinical deterioration. Incubation is usually a median of 4 to 5 days. Dyspnea usually occurs 6 days post-exposure. People are mostly hospitalized 8 days post-exposure, and I think what we've all learned is that people can deteriorate very, very fast, and usually admission to intensive care happens 10 days after exposure. There's a lot of discussion of when to intubate the patients, and it looks as if you intubate them too early, that may be unfavorable. So there are some papers around looking at that as well. I don't want to go into the details of all the clinical symptoms. I'm sure you're very familiar with that. So beyond the constitutional ones, it's really, in particular, dyspnea and dry cough, which were the leading symptoms. And in the evaluation and questioning of the first patients from the Heinsberg cluster, new symptoms were described, including new loss of smell or taste, and that has now just been added from the CDC into the symptoms describing a COVID-19 disease. So that's indeed, I think, helps us to be more specific about manifestations and also distinguishes it potentially from other upper respiratory infections. So new loss of smell or taste seems to be very characteristic for COVID-19 infection. And then from a clinical standpoint, just 2 remarks in addition I would like to make. The first one is the cardiovascular involvement. When we got prepared for the COVID-19 response, we contacted our Swiss colleagues and they said, you'll be surprised, but a lot of the patients have a positive troponin test. They may even present with a picture where you clinically would think that they might have a myocardial infarction. So please think also of myocarditis and myocardial involvement in COVID-19. And indeed, a subsequent paper in JAMA Cardiology has really highlighted the association with the high inflammatory burden and vascular inflammation, myocarditis, and cardiac arrhythmias in the context of a SARS-CoV-2 infection. And the other, I think, clinically really relevant, more recent finding is the changes in coagulation and coagulopathy, the increased risk for thrombosis. We also had one patient, and again, the Swiss colleague said, if you have someone with a stroke, also think this could be a complication within a COVID-19 disease. And one of the first patients who came actually had a stroke, and we thought he has a stroke and not COVID-19, but he was, in the end, the only one who really had a COVID-19 infection. So that's really important, and subsequently, there's also been a recommendation for prophylactic low-dose molecular weight heparin unless there's active bleeding or a very low platelet count to counteract some of these coagulopathies and changes which make the patient prone for thromboembolism. Now, I know there's a different program from FLS targeting patients with HIV co-infection. I just want to highlight that there also have been patients identified here in Germany with HIV who had a COVID-19 infection. You are well aware that some centers have proposed that potentially the course of disease may be a little bit different. For sure, it doesn't look as if patients with HIV have a higher risk for disease progression. There's the first case series of 33 subjects which has been submitted to infection. And of note, though, 3 of the 33 patients which are described here have died. So it does look that some patients do take an unfavorable course. It's important to highlight that the patients who died, though, mostly were older and also had significant comorbidities. Obviously, this is a very small number of HIV patients from all the HIV patients in Germany. So I think the question of how many are really affected can't be answered from a case series. But I think at least we can say that most of them had a mostly mild to moderate course. Hospitalization, depending on whether you how you count the patients, was between 21 and 24%. The overall hospitalization rate in Germany has been around 17%, so very similar. And in the context of discussing whether some of the HIV antivirals may have an effect on getting infected, like being preventive, and also thinking of the phase 3 PrEP trial, which is being done with low-dose hydroxychloroquine and TDF in Spain for healthcare workers, I would say that the majority of the patients in this case series was on TDF or TAF, so at least not suggesting 100% protective effect. It doesn't allow to say more because it's just a case series, but clearly a lot of people who had one of these 2 components got infected, so it's not fully protective against a COVID-19 infection. So I want to close with some learnings. And I think if you want to really downsize the epidemic and make sure that your medical system does not come to a meltdown, I think testing availability and rollout, as well a time point of implementation of other measures like lockdown and social distancing are really crucial. And you could really you can really see how worldwide the response of an individual country really determines the rate of new infections and deaths subsequently. So the more aggressive you prevent infections and the more social distancing you implement, the more likely you are to get away with a smaller burden to the healthcare system. I think that the mortality rates are very dependent on who's tested and the affected population. So if you have a more younger patient population, then you're going to get away with less deaths because the mortality is simply higher. If you get an outbreak in a home for the elderly or people who have significant disease or in specific homes taken care of, then we also saw very high mortality rates, but on average, the population affected was very young, so I think that does explain some of the differences. And then again, obviously, early testing and isolation and preventing the spread to more vulnerable patient populations is crucial. Implementation of infection prevention control strategies is important. And I think I would say that so far we have no protocol would suggest any recommended antiviral or treatment approach except participation in clinical trials. So there have been various remdesivir trials in Germany, but there's no protocol in Germany which says we should start with antiviral 1, 2, 3, because we believe that currently that is all experimental and should only be done in controlled clinical trials. I want to close with a paper from Switzerland, which I think is very important because it sort of outlines the testing strategy, that testing followed by contact tracing and isolation of those with positive results will keep the basic reproduction number, which is usually around 2 to 3, under 1, and that will prevent the majority of possible transmissions, and I think will really contain that the healthcare system does not melt down under the pressure of people requiring intensive care and mechanical ventilation. I think the antibody testing may be providing some additional information of how far it has already spread in the population, particularly in countries where no testing was available initially, but it will not help during the acute diagnosis of disease. And I think one of the big interventions, which is very controversially discussed, but has currently been implemented in all provinces, is that it's now mandatory to wear a mask in all shops, buses, trains, so anywhere where you get in contact with other people. And at least from the Asian experience, because that has already been performed in some of the Asian countries with very low infection rates, it seems to work. There's always a discussion of how much can it prevent. It's clearly not an absolute 100% protection, but it does seem to lower the probability of inhaling aerosoled coronavirus, and as such probably has some effect. And I'm sure the trend in new infections of the next couple of days since this new rule has appeared, and we by law are enforced to wear this unless otherwise you have very high fines you have to pay. We'll see whether this helps to further mitigate the spread of coronavirus. So I'll close with saying you cannot fight a fire blindfolded, and we cannot stop this pandemic if we don't know who's infected. So testing, I think, is the key thing to do. Thank you very much.